multidisciplinary team, the special knowledge in stroke unit. It is not just the neurologist, we need a whole team of the people. And the use of the stroke unit, which is equivalent to thrombolysis. The effect is equivalent to thrombolysis and it can be used in every stroke patient, even if though you come beyond window period also and in hemorrhages also. If you combine stroke unit and IV thrombolysis in all the acute stroke patients, 2/3 of our job is done. This is the most important concept that I want for the physicians and the emergency physicians to take forward. And the organized stroke units are staffed by not just neurologists, but the emergency physicians, ER nurses, paramedical staff, CT technicians, lab technicians, radiologists, neuroradiologists, and paramedical rehab dietitians. But however, is it worth making this stroke team and stroke unit? Yes. All the meta-analysis of the stroke unit trial, more than 4,000 participants showed they reduced the mortality by 20% and disability by 25%, and the effect size is comparable to TPA. When we combine them, that is the best. The second landmark trial came after 12 years, this ECAS-3 by Werner Hacke in Germany, where the window period, which was very narrow initially, because of the narrow window period, we were not able to thrombolyze many patients that time. Now it is extended to 4.5 hours. It still stands at 4.5 hours even now, though there are some studies to extend it to the 9 hours. But still they have not come into the guidelines. We are still at 4.5 hours. And in addition to the clinical trials, the treatment has been given in many community hospitals across the world in the 6 most registry. Even in India we had 6 new registry where 12 centers of India participated way back in 2008. And it also showed safety and efficacy of IV thrombolysis delivered at the community level. So this is the evidence. And the other thing that I was mentioning is time is brain. That is the most important concept. You need not worry as long as they are within the 4.5 hours. Whether the patient is male, female, young, old, high NIHS score, low NIHS score, and all these things they don't matter as long as you can deliver the IV thrombolysis within 4.5 hours. And every minute matters. Even 15 minutes delay or earlier will make a difference in the outcome. They have measured every 15-minute epochs and then they calculated. They did show. So the most important concept as our surgeon has set forward is to start a stopwatch. Whenever the patient walks into your AR bed, you start the stopwatch. And we have the same type of watches all across in our stroke center. In the emergency, in the stroke, in the CT, in the MRI, the same type of clock will be there showing the time. And one person will be carrying the stopwatch and then driving the entire team to do it earlier. So let us go through a few steps of this IV thrombolysis. The minute the patient comes to your ER, all that you have to know is what is the time loss known well. This is the so-called window period. They may not be able to tell the onset, but you should ask when the patient was normal, till what time you are sure it is normal, and then that's how you calculate the window period. A brief history, a quick examination with NIHS score, and Dr. Sanjay was very elegantly showed us all the scales. You just need to do a quick NIHS score. Bedside sugar is the only laboratory needed, no need to wait for the labs, the present guidelines are, and you should have an informed consent and the inclusion-exclusion criteria. The eligibility criteria is only a clinical diagnosis of acute ischemic stroke with a measurable neurological deficit, onset within 4.5 hours, age more than 18 years. And coming to the contraindications, once upon a time we all kept our vials there, afraid to give thrombolysis. There were a big 2-3 pages of contraindications. But now most of the contraindications have become only relative, and only the absolute contraindication for thrombolysis is only when you suspect or you have blood in the brain. That's the only absolute contraindication. When clinically if you suspect subarachnoid hemorrhage, then be careful. If there is a blood events minor or small, you have to be careful. And all other things are relative. For example, previous ICH, as I will tell you in the next few slides. Once upon a time it was absolute contraindication. Now we have guidelines. Head trauma, prior stroke, intracranial spinal surgery within 3 months, relative. Known structural GI malignancy, GI bleed within 3 weeks have become now 2 weeks. Major extra intracranial surgery within 14 days, and all these checklists you will have. Coagulopathy, I will tell you the details. Only if you suspect patient will have coagulopathy, you need to do the coagulation profile before IV thrombolysis. Otherwise, it is not mandatory according to the current guidelines. This is a very important concept that the ER physicians and the students must be noting down. Use of LMWH within the last 24 hours and other things. We'll go through it. This is the one which is timeline showed by our Dr. Saujanya. However, this is only the NINDS one, which was valid till recently. Now we have shortened all these timelines to make the at least 30 minutes, half of it. So cut down the time frame from everything, like door to doctor 5 minutes, door to neurology 10 minutes, door to CT 15 minutes, door to needle is 30 minutes. That is our aim at present, to make it door to puncture time of 30 minutes. And after eligibility criteria are met, take informed consent. And if it is RT you calculate as 0.9 milligram per kg with 10% bolus remaining given as 1 hour. If it is TNK, which has become now standard of care across the world because of ease of administration, and they calculate the dose of 0.25 milligram per kg with a maximum of 25 milligrams. It's a single IV bolus of 5 seconds. Admit the patient for continuous monitored bed in the acute stroke unit and monitor for BP. Diligently, you keep your resident by the side. Both sides you check the BP, and whichever is the higher side, you keep the resident diligently check the BP every 15 minutes for 2 hours, every 30 minutes for 2 hours, 6 hours, and every 60 minutes for the next 16 hours. This is very important. And post thrombolysis for the first 24 hours, don't puncture or don't do anything unless it is a really emergency. And repeated NIH scoring to be done. And after 24 hours, the usual stroke treatment resumes. You do a repeat CT to rule out any hemorrhagic transformation, and you load them with single or double antibiotic as the case may be, and all the other secondary preventive therapy will start. Repeat CT within 24 hours. This is the simplistic IV thrombolysis protocol. You need not have MRIs, perfusion scans, all these things. This thing can be done in the district government hospitals and every district headquarters. That is the whole purpose of this. And coming to a few problems arising post thrombolysis, the most dreaded complication is the symptomatic intracerebral hemorrhage. How do we suspect it? If the patient has sudden deterioration in the neurological status like NIH score drops, or the patient complains of headache, vomits and becomes unconscious, or the BP suddenly shoots up, any change in the neurological status or in the hemodynamic status, stop the lysis if it is ongoing, and immediately rush for a repeat CT scan. At the same time, take a blood sample for the fibrinogen, BT, CT, PT, NR and APTT. Nowadays, we have factor 4 PCC, what all the emergency physicians must be using. It's there in the emergency. You can antagonize it within minutes. You can give 2 vials immediately and then repeat if required after the fibrinogen levels. You can give your cryoprecipitate if it is not available, factor 4 PCC, and then you can call in your neurosurgeon to do surgery if required. And this is the original picture of the NINDS patients. It is no more that ghastly and no more that frequent. That was 6% at that time, NINDS time. Now it is now almost just 3% with a good selection and very few stitches all of us are facing these days with proper selection and proper monitoring of the patients. And for the students, this is the grading of the symptomatic hemorrhage. HI1 is just a few scattered petechiae, HI2 is confluent petechiae, which is again they don't mean anything. And but PH1 is hematoma and PH2 is the most significant and serious one to occur in a patient, which may worsen their prognosis or mortality. Angioneurotic edema described by with altiplase is once in a while we used to face. It has to be dealt with like an emergency and using every antihistamine and even adrenaline sometimes, but not yet well described in TNK. It can happen in TNK, very rare reports we have. And now the most important thing is, this is a theory, but when we come to face a patient directly in our ER, there are 101 questions. Every time each new patient will pose a different question to us. It's not so simple as it looks. Let us go through some of these questions which will arise in our mind when we face an acute stroke patient. What imaging and lab testing is mandatory before IVT? What do we do with the unknown windows or late windows or wake-up strokes? What do we do with minor and severe strokes or recovering fluctuating strokes? What about the age? What about children? What about the patients on antiplatelets and all those conundrums? We'll see according to the time. So, case report. A 30-year-old male smoker came with left dense hemiplegia, window period 3 hours, NIH 10. What is the first investigation you will order? Students, I want little bit interaction. What is the first investigation you will order? 30-year-old came to your hospital emergency. First, tell anything. Sir? Sugar. Okay, bed said sugar. And then? CT scan. How many will order MRI with DW other than Saujanya? Who who will order MRI? Even surgeon will not MRI. Salil, no. So I'll tell why not. So no MRI in this patient, because that is the reason why I showed that 15 minute, every 15-minute delay will worsen your deficit. So MRI will take at least 15 minutes more. So I think I will change your school to my school. No MRI in a patient who comes within 3 hours with a typical stroke. Even if you have MRI, please don't do. Just get a CT scan, lyse him, and then take him to MRI. That 10 minutes, 15 minutes will make a difference in the outcome. This is a very important concept.
Madam, only chronic cases we are going for MRI.
Only
CT
yes, sir.
only.
Not you, sir. My colleagues are mentioning, that is why I am listening. I want. There are whole world is divided between MRI based CT, stroke management, and CT based stroke management. These are all communist, both types. They are always fight among themselves. CT or MRI, CT or MRI. All our stroke conferences have these debates.
Only CT, madam.
That's correct, sir. You are on the right side of the right decision. So please don't waste time in a typical stroke patient coming with a typical stroke. Just do simple CT, do blood sugar. As Dr. Mohan Kumar was suggesting, first do a blood sugar. If there is no hypoglycemia, do a CT scan. If there is no blood in the brain, just thrombolize him within the CT scan. That is how we can make our door to needle time 20 minutes. The lowest in our center is 20 minutes. The highest is of course 60 minutes. That is the different causes will be there. From our side, we should try to make it 20 minutes. Right. So even this has come to the guidelines. Given the extremely low risk of unsuspected abnormal platelet counts and coagulation profile in a typical patient, it is not mandatory to wait for the PTINR. Once upon a time we used to do that, but now it has guidelines have changed. You just send the labs, but don't wait for it. Give thrombolysis. Okay, the next one. And because again I was want to mention again, every minute matters in a stroke outcome. If the patient presents, then there is no need for any other labs except the sugars. 87-year-old lady came with left side dense hemiplegia, window period 3.5 hours, showing minimal ischemic changes. Can we thrombolyze? Yes or no? Yes, we can thrombolyze everyone up to 100 years. IST 3 is the biggest, one of the biggest stroke trial that has been done. Half of them were more than 80 years. So we have very good data to thrombolyze up to 100 years. We ourselves will become 80 plus sometime. So we don't want ourselves to deny our treatment if we require. So this is a very important concept. Age is no bar if they are eligible. The highest is 98 years. Yes, we have done 94 years. We have done 90 years recently, and all of us have done all these patients. Excellent. And the recent trial, there is another trial which is called, they tested in patients more than 90 years. So again it is shown benefit. The risk is less than the benefit. What about children? This you need not know, because this can be done only by stroke neurologists in special situations. We did thrombolyze in our center and many other centers to children less than 18 years. From 10 to 18 years, many of us do, and 5-6 patients we have, they all did very well. And what about the time window? That's the most important problem we always face. This 35-year-old obese young man came with right side dense hemiplegia with a window period of 5.5 hours. Should we give IVT or not? Young person. But he crossed the 4.5 hours. How to decide on this? The second, other question. On a Sunday, 7 a.m., your neighbor comes saying, "Beta, your uncle not waking up from bed." You go and see they have slept at 12 o'clock after watching a movie together. That means last known well is 12 o'clock. And then when you go and see him, he has an NIH of 8, and you take him to the hospital, CT scan, no hemorrhage, and what do you do? So the presentation as wake-up strokes are unknown. Window period is very, very common. 25% of the strokes are more common that way. Our people are not very conscious. And there is the concept of tissue window. It is not the clock time that is important, but the tissue window, which may matter with every person. There are somebody called slow progressors. Some of the patients, even though they have MC occlusion, can have very small infarct even after 24 hours after it. And some people may infarct within 1 hour. So not even 4.5 hours, within 1 hour they can have infarct. So these are physiological differences and the concept of tissue clock. Time is brain, but each brain has its own time. This is a very important concept. So there is a total paradigm shift to assess the tissue window. How do we do that? There we need all these advanced stroke imaging. Your CT perfusion and CT angio, multimodal MRI, diffusion and perfusion and all the things. This is the where we have to use these things. And what are the studies that we have proved this concept? The wake-up trial is the most important one, extended trial and ECAS-4. All of them have shown how to select patients in the extended window and lyse them safely. And this is the extend up to 9 hours with a CT perfusion protocol. And this is the wake-up stroke by Tamala from Europe. And they have simple paradigm they have evolved with proof. You just do a diffusion and flare MRI. In these patients, in wake-up patients, MRI is the choice. You just wheel him into the MR, do one diffusion and one flare cut. If there is a difference, immediately thrombolize in the MRI and then do MRI angio or other things. This is a very simple concept. So this is the wake-up trial. It has come into the guidelines also. We can do it. To summarize, late window is useful in slow progressors with good collaterals. The important scenarios are, all of us can use this DWI flare mismatch, core penumbra mismatch if you have a CT perfusion in your place, and experienced stroke neurologists can use clinical CT mismatch. This is only the experienced people can do. And what about minor strokes and rapidly improving strokes? The patient will come, you see him, you have dense hemiplegia, he goes to CT and comes back, he says, sir, I am okay, I am alright, I am lifting my hand, I am already better. What do you do? Whether to give or not to give? This is a very, very difficult decision for anybody. So, a 48-year-old university professor came with slurring of speech and mild upper limb weakness, right hand. NIH score is only 4. By definition, it is a minor stroke. Window period 1 hour. You want to thrombolize or not? Yes, okay. A 70-year-old lady came with on diabetes, on double antiplatelets, came with mild dysarthria and left to just shift at 3.5 hours. Do you want to thrombolize or not? Give the choice to the patient or the attenders. May or may not thrombolize. Minor stroke, left side. If it is less than 4, don't thrombolize. That is also we have a clear guidelines. Decision in minor strokes and rapidly improving strokes is if NIH score is 4 or above, you can thrombolize. If it is less than 4, but the deficit is about aphasia, visual or sensory extinction, complete hemianopsia, you have to thrombolize because they are very important deficits. If it is 4 and they have MC occlusion and the patient has fluctuating weakness, again you can thrombolize because patient again can become deterioration. If you don't thrombolize, 30% have poor outcome. These are the few concepts that are given. But if the patient definitely has minor stroke, like only numbness of one hand, only little bit ataxia, only little bit dysarthria, definitely minor stroke, don't thrombolize. You do more harm than good to those patients. What do you do with these patients? You start them on DAPT for 21 days according to the point trial. These are all very clear-cut guidelines. And what about severe stroke? Once upon a time, if the CT scan shows infarct, we are afraid. Now, even if there is a big infarct, more than 50%, up to 2/3 infarct is there, you can still thrombolize within 4.5 hours. Because the outcome, ultimately, the 3 months outcome is better in these patients with the thrombolysis rather than denying them of the thrombolysis. Severity of stroke is not a contraindication. Of course, you need, and this mimics my colleagues have dealt, even if it is a mimic, if you suspect a mimic, if you strongly suspect stroke equally, then you can still thrombolize because if mimic gets the thrombolysis, they don't bleed. That's a blessing. So that is one concept where you have to, if you have a strong suspicion, especially the posterior circulation strokes, you can thrombolize. And pregnancy, this is a special situation where only stroke neurologist can take a decision. For thrombectomy is if the patient has LVO, or Chaitanya can go and do a mechanical thrombectomy in a cath lab, that is easier. Even if the patient requires, you can give altiplase because altiplase is a big molecule, it doesn't cross the placenta. However, these are decisions which is in discussion with the obstetrician, the patient attenders and all the things have to be decided. Cerebral aneurysm, you have clear-cut guidelines, you can go through it in many of these guidelines. The small aneurysms are clipped aneurysms, no contraindication. Only if there is a giant aneurysm, it's a contraindication. And what about trial stroke? Again, we are afraid. Previously, the guidelines say if there is a stroke within 3 months, don't thrombolize. But now it has become relative. The data has shown only within first 14 days, if the patient gets a recurrent stroke, then it is risk. If the stroke happened 1 month back, minor stroke then, and now again patient has a moderate stroke, now you can thrombolize, because that's the way they require. Otherwise they will have great deficit. These are all the very subtle things where you have to think 360 degrees. And the recurrent stroke within 3 months is not a contraindication, 100%. Risk of switch is not higher in patients within the criteria. Subacute small strokes within 6 weeks, we can do thrombolysis. Silent infarcts, you can thrombolyze. Leukoariosis, you can thrombolyze. And what about patients who had ICH in the past? Again, we are afraid. Once upon a time, we never gave them IV thrombolysis. If it was a first intracerebral hemorrhage 3 years or 4 years back, when the patient did not know that he has hypertension, that is when they was not taking any antihypertensives. Then now the patient has a ischemic stroke of moderate severity, and his BP is well controlled, and is within 4.5 hours. No other contraindication. You should give him the benefit of thrombolysis. In malignancy, nowadays patients are living longer and patients are living better with malignancy. All of us know. It is no more a thing that to deny them. If they have 6 months or more life, you should go and thrombolyze, telling them the risk-benefit ratio. And what about MI? This is another problem physicians will be facing. If there is concurrent TIA and MI, you can go and do thrombolysis, and all other things are relative. Only if the patient has a severe acute anterior wall MI with a thin myocardium and the risk of rupture, don't give. All other things, posterior MI, the inferior MI, all these things you can thrombolyze if you are otherwise eligible. And the patient has significant deficit. Minor stroke, you don't take the risk. Major stroke, you take the risk. And other cardiac conditions, endocarditis contraindication, pericarditis contraindication, and thrombus, cardiac myxoma, you can give if the patient you think is a thrombus which is causing the stroke. Other comorbidities, sugars high we have to treat, low we should not, we should wait whether it is only hypoglycemia can mimic stroke. If the patient improves and no other deficit, we can wait. If high sugars, you treat the sugars and give altiplase. CKD and hemodialysis, you can give IVT if IVT is normal. Sickle cell disease, it is indicated. Suspected dissection, hypertension MCA sign, if you can give if there is a large vessel stroke. What about patients on antiplatelets? Everybody is on some drug or other, more than one drug, many times. If the patient is taking one drug like aspirin or clopidogrel or ASA plus clopidogrel, IVT is allowed. If the patient is taking two drugs, aspirin and clopidogrel we can give, but aspirin with ticagrelor we cannot give. Ticagrelor is a contraindication for the IV trauma. Risk of bleed is more. What about oral anticoagulants? Patient was on warfarin, he gets a large stroke. You do your PTINR here. You require the PTINR here. If it is less than 1.7, you can thrombolyze. If it is more than 1.7, you cannot thrombolyze. The patient was on heparin treatment dose, he cannot give. And what about patients with DOACs? There are so many patients on DOACs. And we can give idarucizumab reversible for dabigatran and neutralize and give even without reversal. If patient has a severe stroke and the drug was given 48 hours before, you can still thrombolyze safely. If the drug was given within 48 hours, you need to do the levels. I think these are the things which we can individualize. So the latest meta-analysis showed IVT in DOAC patients is safe, is effective. You need not worry so much about the risk of bleed. Half of them are rivaroxaban, half of them are dabigatran. If it is available, you give idarucizumab and thrombolyze. If not, you can tell. What about in large vessel strokes? If you have a large vessel stroke, do we need to thrombolyze them or directly give them to the interventionist? This is a question faced by some few years back. Even in the era of thrombectomy, we need to thrombolyze these patients if they come within 4.5 hours. What are the studies that showed this? These are the other trials. Direct empty, debit, MR clean, no IV, swift direct and direct safe. All these 5 trials have tested this concept of direct thrombectomy versus IVT plus thrombectomy, and it is very clear that successful reperfusion less common in MT alone, and we do have to thrombolyze these patients, and symptomatic IC did not differ. This is very clear. However, this is another very interesting, this is trace 3? Yes, from China. What does this, though not immediately applicable to us, we should also do our own study. what they did was the patient has LVO and they did not have the access to thrombectomy. These patients up to 24 hours they gave tenecteplase. And they found these patients were better without IVT. So this is a very important thing that has come from China only. So we need to replicate this before we give those guidelines in this group of patients. Mechanical thrombectomy is not available for many of us in our country also. This is a very important concept. If it is proved in the future, we may use that concept to increase the thrombolysis period up to 24 hours. And this is a Hermes meta-analysis. All of them showed thrombectomy, IVT plus thrombectomy, ship and rip. Give your IV thrombolysis, ship and then send to the center where they have thrombectomy. Again, guidelines 1 and A. Patients eligible for IV arteplase should receive IV arteplase even mechanical thrombectomy is being considered. TNK, I think there is one more talk with TNK. The speaker is here. Okay, I think you will cover it most. TNK is nothing but a genetically modified arteplase to make it more fibrin specific and more half-life. And all these advantages they have. Clinical adverse, short preparation time, no requirement for second intravenous, lower cost per dose. And it has shown to have a better functional outcome in some of the trials, but recognition and safety are equivalent to the arteplase. And there are so many trials. It took 20 years for tenecteplase to come into common use, and India is one of the few countries in the world to accept tenecteplase as standard of care in acute stroke, before Europe, before Canada. Evidence is, of course, we have a lot of evidence, and it showed good clinical outcomes, excellent clinical outcome, no increased mortality, no increased sick. In large vessel occlusion, it is preferred. When compared to arteplase, it is the extend IA. It has shown that if you give tenecteplase versus arteplase, this is better outcome in the patients with. This is the Campbell et al. Bruce Campbell showed this data. 22% with tenecteplase and 10% with arteplase with very high p-value. So the guidelines say if the patient has the LVO and both the drugs are available, it is preferable to give tenecteplase rather than arteplase before your patient goes to the thrombectomy. And this ACT trial, all of us know this is the ACT trial which has changed everything, and it has given us proof of concept, and this changed the guidelines across the world, especially Canada adopted it to tenecteplase as the first preference, and then the expedited European Stroke Organization recommendations to use tenecteplase equally, and these are the recommendations from those guidelines. What about any other drug that is coming up? Yes, retiplase. This is one being tested again in China. The advantage is retiplase, you need not worry about the patient weight. Every time we say, what is the weight of the patient, what is the calculated dose? These are fixed dose. Only 2 doses are given. There is a fixed protocol. If it is useful, it is cheaper, and the advantage of dose fixed. And the mobile stroke unit, as I was mentioned, it is another way to decrease the down to injection time, and which can be done CT scan in the mobile stroke unit and then give the drug within the MSU. And the other thing is how the technology is getting used. We all know rapid software to give us the large vessel occlusion, and they are also using this AI-based pre-hospital trials. If the patient data is put into that AI, it will tell us this patient looks more like large vessel stroke. Take him to a thrombectomy center, or this patient looks like minor stroke, thrombolyze. These are the things that are coming up off late. This is the MAP stroke study recently presented in the ESOP, and all these things are helping us to decrease the time from the onset to the thrombolysis. And of course, all of us use our low-cost telestroke, telethrombolysis. All of us are on the WhatsApp. All of us be seeing the immediately uploaded into the WhatsApp. And then all of us take decisions and put it in the group, and the resident will thrombolyze the patient. However, despite all the things that I have spoken, the most important barrier is still to get the patient from home to the stroke ready center. And pre-hospital is the most important gap that all of us should be working together. Therefore, the take-home message is IVT is the mainstay of acute ischemic stroke, irrespective of subtypes. It is a safe and effective the treatment of acute ischemic stroke with disabling symptoms less than 4.5 hours. If non-disabling, don't give. Agents TPA, TNK, standard of care, retiplase is also coming up. TNK superior with patients with LVO, the time windows for IVT become flexible with advanced imaging. Emerging new lighting agents and adjuvant therapies is a promising feature. However, the most important challenge is to bridge the treatment gap to improve the decimal 1% IVT to 10% in India, to develop stroke centers in every district manned by neurologists, physicians and emergency physicians to improve the pre-hospital care. And time is brain, but each brain has its own time. Don't deny anybody and try to get as many patients as much into the IV thrombolysis. Thank you very much for your patient listening.
Thank you, Vijaya, for an excellent lecture covering all the